J'ouvre maintenant la séance.
I call this meeting to order.
18 of the House of Commons Standing Committee on Health. Nous reconnaissons que nous nous réunissons.
We recognize that we are meeting on the unceded territory of the Algonquin Anishinaabe peoples
In a hybrid format pursuant to standing orders. And I want to remind everyone, for those of you who are new to the committee, about the following points. Wait until I recognize you by name before speaking. For those of you who are on video conference, click on the microphone to activate your mic, and please mute when you're not speaking, or else we get feedback, and it is very damaging to the ears of the interpreters. At the bottom of your screen, for those of you online, you will see select the appropriate channel for interpretation. You can either select for English or French. It's a little round globe that you can press on. A reminder that all comments should be addressed through the chair. And again, members in the room, you know how to raise your hands if you wish to speak. You also know that you've got this little decal sitting next to you where you should park your phone so that you don't give a lot of feedback to the interpreters. And so the clerk and I will try to manage the speaking order as we see you. Because you're on both sides of the room, sometimes we don't get you first when you put your hand up, so we're trying very hard to cover the room. Now, and I also wanted to say that at the end of this meeting, we have a budget to pass, just 2 budgets, so we just need to just say yes. No, just yes to them at the end of the day. Now, pursuant to Standing Order 1082 and the motion adopted by the committee on Tuesday, September the 23rd, 2025, the committee will resume the study of antimicrobial resistance. I want to welcome our witnesses. There's one in the room, and there are Dr. Bogosh is here with us in the room, and then everyone else, Dr. Leung, Dr. Weiss, Dr. Wright, are all online. So here's how it works. You each have 5 minutes to speak. I will give you literal shout out at about 1 minute, and then you know that you've got time to wrap up. And then I give you a 30-second shout out. And then at the end of that, if you didn't get to finish everything you wanted to say, we have a question and answer period in which you can elaborate on things you didn't get to say. So we will begin, and I will start with Dr. Bogosh, Professor of Medicine, University of Toronto. Professor Bogosh, you have 5 minutes, please.
Thank you so much, and thank you for the invitation to be here today. It's wonderful to see everybody. My name is Isaac Bogosh, and I'm an infectious diseases physician and scientist and a professor of medicine based out of the University of Toronto. I recently spoke about antimicrobial resistance, or AMR, at the Standing Committee on Science and Research, and I'll be making many of the same points here today. I regularly treat drug-resistant infections in my clinical practice, and my research focuses on how these organisms spread around the world, mainly through human mobility patterns. I'm grateful that you're studying this topic because it's got a tremendous negative impact here in Canada and, of course, around the world. Now, as you've heard, AMR arises from the misuse and the overuse of antimicrobial drugs, which renders them ineffective and causes substantial morbidity and mortality. I see this at the bedside as a clinician, and I appreciate some of you in the room are physicians as well and have dealt with this too. AMR leads to the delayed initiation of appropriate antibiotics, and it results in predictable negative consequences. What's interesting is many people might not be aware that about 70% of the global antibiotic consumption is in agricultural animals, and only 30% of the use is in humans. So this imbalance underscores the importance of what we call the One Health concept, which basically recognizes the interconnectedness of human, animal, and environmental health. And because of this, we need to take a collaborative and, pardon the buzzwords, but truly a cross-sectoral approach to combating AMR, because it's a massive problem. Right? A recent study published in The Lancet estimated that there were about 4.7 million deaths per year where AMR played some role. And just to put that into context and perspective, that's more deaths than HIV, TB, and malaria combined. And every country's impacted, but of course the lower resource settings are disproportionately impacted. And this is one of those issues where we're not going to invent our way out of it by developing new drugs, right? In an arms race between creating new drugs and microbes adapting to these drugs, the microbes are going to win every time, as they've done in the past. And Canada, relative to the rest of the world, is doing relatively well, but pardon the pun, we're not immune. We have national strategies and regulations over antibiotic use. We have infection prevention and control initiatives that mitigate the impact of AMR spread in healthcare settings. But the uncomfortable truth is that we can do everything right in Canada and still fail. We know AMR, like just about every other pathogen, they don't respect political borders. So we can see the development of resistant organisms on one side of the planet, and they move to Canada and elsewhere around the world through travel and trade. And while AMR is appropriately framed, as I mentioned, as a One Health issue, I'd also urge you to consider this a health security concern. So as we saw during COVID, our supply chains for diagnostics and therapeutics were fragile, and they might be further strained by growing geopolitical instability. There's an ongoing war in the Ukraine, for example, that could spread to other NATO countries. We've already had 2 allies invoke Article 4 in 2025. And just for an example, in this conflict, up to 80% of the combat wound infections are resistant to conventional antibiotics. So this would pose a serious risk should Canada be drawn in. In addition to that, we know that Russia's past biologic weapons program is well known to have developed drug-resistant pathogens. So at a time where Canada has pledged to raise security spending to 5% of GDP, failing to integrate AMR research and preparedness into that investment would overlook a critical threat. But you know what? It's not, I can't say this with a straight face. I was going to say it's not all bad. It actually is, right? There are large surveillance programs to study and track AMR, right? We've got the WHO that leads a big program. The US CDC leads a big program. But of course, as you are well aware, major partners are massively scaling back funding and global health leadership is imploding. So this leaves us more vulnerable, but it also presents a major, major opportunity for Canada to fill this vacuum as global leaders in healthcare and public health and health security with a focus on combating AMR. So what's a smart path forward? We can take a true intersectoral approach with a national and global perspective.
1 minute.
We can strengthen antimicrobial stewardship programs and infection prevention and control programs in Canada and abroad. That also means not just in healthcare, but in agriculture and in veterinary sectors. We can enhance AMR surveillance in Canada and abroad. We don't need to reinvent the wheel. These programs exist. We can just help support funding them. We can invest in research and innovation in Canada and abroad, so supporting public-private partnerships, enabling Canada to be self-reliant, supporting R&D for new diagnostics and therapeutics. We can raise public awareness campaigns for the various sectors on the dangers and misuse of overuse and misuse of antibiotics. And then we can leverage the security aspect of AMR to fund many of these initiatives. So AMR isn't a distant threat. It's already here. It endangers both Canadian and global health. We can act now, or we can face far greater consequences in the future. Thank you very much for your time.
Thank you very much, Dr. Bogosh. On the button. Really good work. And I now go to Dr. Victor Leung, infectious diseases physician and medical microbiologist, and he is on video conference. Hello, Victor. How are you? Good to see you.
Hi, good afternoon. So I work as an infectious disease physician and microbiologist in Vancouver, British Columbia. I want to highlight today some maybe 3 aspects that I see on a daily basis that I think are important to emphasize that highlight the problems that we face when dealing with infections. I'm going to divide it into 3 categories. The first is treating infections that have multi-drug resistance. And the second category is the problems that we have currently with infection prevention and control and some of the antimicrobial stewardship work. And then finally, emphasize the importance of vaccines and how we need to strengthen our national vaccination programs, because I think that the current approach is not meeting the necessary demands that we can achieve with benefits from vaccination as an approach to AMR. So from a clinical access point of view, on a daily basis, we deal with infections that often are multi-drug resistant. And when we're seeing patients with drug-resistant infections, we're already downstream from the preventative approaches. What we're dealing with now is access to antimicrobials and selectively choosing the best antimicrobials that will help control the infection. The problem in Canada is our special access program that is outdated. Several years ago at the national meeting, there were changes made that I think we all advocated for in terms of accessing drugs that are essential in treating some of these multi-drug resistant gram-negative infections. There have been some improvements, and locally at our hospital, we're the only hospital in British Columbia with future use applications for 2 of these antibiotics. But that's not the case in many hospitals across the nation. When they see an infection that requires treatment with antimicrobials that are not available on formulary, they have to go through an inefficient process to get access to the drug, and the delays in access are problematic in dealing with AMR. What I think needs to be considered in a solution for this is revamping our incentive programs so that we have, like other G7 countries, better access to antimicrobials along with built-in antimicrobial stewardship mechanisms to ensure that we're not overusing them. Because the problem, as mentioned before, is overuse, but at the same time, access to essential antimicrobials in Canada are important as we face increasing trends in antimicrobial resistance infections. Secondly, from an infection prevention and control point of view, many programs have been strengthened and surveillance systems have been developed that where we collect data and try to understand trends. The biggest problem I see nationally is that there are fragmented surveillance systems. So if we look towards other countries and seeing their scaling back of investments in infection control surveillance systems, the problem in Canada is that the access to data is delayed. So an example is if we look at the Canadian nosocomial infection surveillance program and we look at the timeliness of data, there's often lags up to 1 to 2 years. Similarly, for other infections where we have provincial surveillance programs, the data is not collated, aggregated, and shared publicly with the users on a timely basis. And that defeats the purpose of a rigorous surveillance program in Canada.
1 minute.
And finally, for vaccinations, we know that vaccinations have many off-target benefits, and the impacts on preventing diseases, hospitalizations, and then subsequently hospital-acquired infections are tremendous. The problem with vaccinations in Canada is although we have national standards and recommendations based on science, the current supply chain funding model in public health budgets needs to shift. It can't be seen as just a pot coming from public health, and it needs to come nationally from a health budget and how we should rethink a national vaccination program on vaccine procurement as well as distribution to improve vaccination uptake. Thank you for your time.
I now go to Dr. Carl Weiss, Chief Division of Infectious Diseases and Microbiology, Jewish General Hospital. For 5 minutes, please, Dr. Weiss.
So first of all, bonjour. Thank you very much for inviting me today. I would like to talk about 5 different topics. Some of them have already been discussed by the previous speakers. I've been involved with antibiotic resistance and antibiotic issues since 1995. And I was present at the Montreal conference in 1997 when for the first time in Canada, we started talking about antibiotic resistance. So my first message is antibiotics are essentials for human health. Life expectancy in Canada in 1900 was about 40 years old. In 2025, it's around 82, 83 years old. In 1900, 40 to 50% of newborns did not reach the age of 18. And 3 things change this dramatically. Hygiene, of course, but mostly antibiotic and vaccines. Without antibiotics, we would not be able to do any major surgery, no chemotherapy, no dialysis, no travel. So antibiotics are really essential for the modern healthcare system. And I think it's very important that even though we talk about antibiotic resistance, we shouldn't do antibiotic bashing under the cover of antibiotic resistance. It's extremely important to not to scare people about antibiotic when we talk about antibiotics, but to try to enhance the good perception of antibiotic. And I think it's an important message. Number 2, the challenges of antibiotic. First of all, consumption. About 80% of all the antibiotics are being used in the agriculture world, and this is mostly for economic purposes and not really for health purposes. Only about 20% are used in Canada, 25% depending on the statistics in human consumption. About 75% of all the antibiotics are being used in outpatient and mostly for respiratory tract infection. So this is where in the community, and we don't have a lot of data on antibiotic use in the community. I'm a hospital-based physician at the Jewish General in Montreal, so I'm a bias like many of my colleagues who are distinguished experts, but we always look at the problem from a hospital-based perspective and not necessarily from a general, more community-based perspective. So that's an important point to underline. Prescription. In the vast majority of the world, you don't need a prescription to get an antibiotic. And because we live in an open world, out of about 200 countries around the world, the vast majority, 140, 150, you might be able to get an antibiotic without necessarily a prescription. It's not the case in our country, which is a very good thing, but we have to be careful of this because obviously whatever happens somewhere else will end up impacting our own environment. The other thing is we're opening the prescription to more and more prescribers for all kinds of reasons. That needs continuous education of healthcare professionals who are not necessarily very good at prescribing antibiotic. Very often, in a defensive model, they prescribe antibiotic not to be scared to provoke some problems. The next one, I'll do it in French. La production des antibiotiques. C'est très important.
So the production of antibiotics, it counts knowing that the production of antibiotics is fundamental to getting what we need in our country. There's something very important called the API, the active product ingredients, which is the basis of antibiotics production. And right now, that production is delocalized mostly to India and China, such that we are often unable to produce locally some antibiotics and truly depend on the ingredients coming in from other countries. There's also another major problem, counterfeiting of antibiotics, and this is largest in this class of medication, more so than any other class. So many medications can come in to the market indirectly, directly, leading to antimicrobial resistance.
So we have to make sure that in terms of definition, measurement, monitoring, and comparators, we are at par with other country. Definition, it's not very easy. It's sometimes difficult. Measurement, there are many ways to do it, and we don't have like a good way to measure it all the time. Monitoring, we have silos in Canada, so sometimes it's a bit more difficult. So we have some weaknesses in our country, mostly that we don't have a major
30 seconds.
Pharmaceutical giant to produce antibiotic. And I think we are a small market. We have certain things that do very well in agriculture. We have to improve our human networks. We have to share health data between provinces, and we have to educate the Canadian population a lot better. Thank you very much for your time.
Nice. I now go to Jerry Wright, Professor, McMaster University.
Thank you, Madam Chair.
5 minutes, please.
Thank you very much, Madam Chair and honorable members. And if you'll permit me to offer my condolences on the news that Kirsty Dunklin passed yesterday, who is a huge champion of this file and a colleague to many of you in the room, and to a huge help to those of us working in AMR. So I want to speak to you today in my role as an academic researcher. So I have started my lab at McMaster University over 33 years ago, working in the area of AMR and antibiotic discovery. I have advised industry and government and not-for-profits on antibiotic innovation, and I founded a spin-out company called Simple Therapeutics in this area. As you heard from Dr. Weiss, antibiotics change the way that we die. Before we had antibiotics, before the discovery of these agents and vaccines, 56% of Canadians died of infectious diseases. We're down to about 3% at this stage. We've also gained over 20 years of life expectancy. So this is unprecedented in human history. But we're poised to lose this, as you know, because of AMR. So my role as an academic researcher is to uncover the molecular basis of AMR, identify potential solutions, and train the next generation of scientists. My lab uses chemistry and biology to study resistance mechanisms and to advance antibiotic discovery. I've trained over 100 master's and PhD students, postdoctoral fellows, and technical staff. The sad news is that very few of these have remained in Canada, and very few are working in AMR research. The reasons for this are structural. Canada currently has very limited biotech and pharmaceutical R&D capacity, especially in antibiotic discovery. Graduates are drawn abroad to vibrant biotech sectors in Boston, California, and Europe. In addition to building and sustaining an international competitive AMR lab, it is also incredibly difficult in Canada. So academic scientists operate like small businesses. We recruit talent, we produce a product which is high impact research, and are constantly competing for revenue. And this comes primarily from the CIHR. These grants are reviewed from grants from the CIHR. These grants are reviewed by volunteers and panels organized by scientific discipline. However, there's no AMR panel at the CIHR. In fact, all the AMR work is lumped into work on bacteriology, fungal work, and parasitology. So contrast this to cancer research or cardiovascular research, where there's multiple sources, multiple panels at CIHR to fund these areas. This structure completely disincentivizes young investigators from pursuing AMR work. So Canada risks losing research capacity in this field. And then beyond fundamental research, translating these discoveries into innovative solutions remains incredibly challenging. Over 4 decades of experience, we've learned that academic findings often see new biotech ventures, yet Canada lacks early stage funding mechanisms to bridge the gap between discovery and application. This lack of support leaves us completely reliant on advances in other countries. We have to wait for others to discover and develop medicines that we need to keep our citizens and our soldiers safe. We don't need to be in this situation. There's a proven model out there. The US Small Business Innovation Research, SBIR program, provides competitive, non-diluted grants to support startups to commercialize academic discoveries. A Canadian SBIR-style program would foster biotech entrepreneurship, create jobs, and accelerate AMR innovation. To illustrate, my lab recently discovered a new antibiotic, which we published in Nature last spring, targets several pathogens on the Health Canada's priority list. We want to develop it in Canada, but without early stage push funding or downstream pull market incentives, these assets risk moving abroad along with their economic benefit. So in closing, I want to urge the committee to act on 2 priorities. One is to increase the overall CIHR funding and to create a dedicated AMR research stream to strengthen Canada's scientific foundation. And second, to establish a Canadian SBIR equivalent to enable the translation of discoveries from academia to industry and ensure Canadians benefit from homegrown innovation.
1 minute.
We are in strange times. Other countries are shuttering or reducing their research and development in infectious diseases. This is an opportunity for us in Canada. With strategic investment, we can help lead the global stage in response to AMR, protecting both our public health and our life sciences economy. Thank you very much.
I now go to Dr. Semrat, Associate Professor of Medicine, Infectious Diseases, and Medical Microbiology at McGill. Dr. Semrat, 5 minutes, please.
Good afternoon. So my name is Makada Semrat. I appreciate the opportunity to address this committee. I lead the antimicrobial stewardship program for a network of McGill-affiliated hospitals in Montreal and also serve as an associate director for the McGill AMR Center. I'll try not to repeat what has been very eloquently stated by my colleagues and friends around the table. My focus instead will be on antimicrobial stewardship, and I'll go a little bit more granular in this area, which is near and close to my heart. So stewardship is really how we govern the use of our existing antimicrobials. Effective stewardship ensures antibiotics are used only when necessary and with the correct agent, dose, duration, so that we preserve the effectiveness of our existing drugs as well as the future pipelines. So in hospital settings, as you've heard, we're seeing rising counts of infections caused by organisms such as the carbapenem-resistant Enterobacterales, particularly among the at-risk populations that we see increasingly in acute care hospitals. So patients with advanced comorbidities, those undergoing complex procedures, and generally staying in hospital for a very prolonged period of time. So while infection prevention and control is crucial for limiting transmission, antimicrobial stewardship, or AMS for short, limits the selection pressure. So the emergence of clinically significant resistance, and that's both at the individual and at the system levels. So in AMS or AMS programs, we aim to reduce overuse and misuse of antibiotics, and this is through a set of very coherent and coordinated activities, such as surveillance of antibiotic consumption, surveillance of resistance, development of treatment guidelines, and this is harder than you'd think, education of prescribers, and very intensive, resource-intensive monitoring, evaluation, and feedback for individual prescriptions, as well as obviously research into effective interventions. So in Canada, acute care hospitals are required to have at least some basic components of AMS programs for accreditation standards, and this requirement has been very beneficial. Successful programs can reduce antimicrobial use by 15 to 20% in the first few years. That has certainly been our case. Even though we have a very complex patient population, we offer services like transplantation, advanced cancer care, complex surgical procedures, etc. Since 2019, we have been able to reduce our per patient antibiotic consumption by 20% and also have decreased the proportion of antibiotics that are prescribed inappropriately. And with these decreases, there are well-documented benefits, such as reduced rates of drug-resistant infections, including C. difficile, reductions in the length of stay in hospital, lower drug costs, etc. But we do face challenges, and I'll briefly touch on just 3 points that are relevant to stewardship in acute care settings. The first is quite obvious, and it is resource allocation. In our network, for example, antimicrobials account for only 3% of the total pharmacy budget, so $4 million per year out of a total pharmacy budget of $130 million. So you can imagine that this does not grab a huge amount of attention from the C-suite. Even when we reduce our antimicrobial consumption by 15 to 20%, that's a nice budget decrease. But after the initial gains post-implementation of programs, we reach a plateau in terms of cost reductions. Yet we need to maintain sustained effort, very resource intensive, just to maintain that plateau. The second challenge I would like to touch on is a bit more conceptual, and that's the fact that AMS programs aim to prevent outcomes that have not yet occurred. So the impact of our programs is much less visible compared to the impact of many other acute care interventions done in healthcare. Infectious diseases generally are an area of medicine where outcomes are not systematically measured. The third challenge is integral to our objective, and it is about assessing appropriateness of antibiotic use. This is a very complex endeavor. We conduct audits by teams of experts, and there is no single standard definition of appropriateness. It is context dependent. There's variability, even among experts that have similar training and practices. But in these challenges lie the opportunities that may be interesting for Canada. We have a single payer system. We have harmonized clinical practices across provinces and a well-connected international community of infectious disease and experts. So we have an opportunity to develop the development of pragmatic definitions and approaches to rating prescription quality, and we can move from qualitative standards of accreditation to scalable quantitative metrics that would measure prescription quality and program effectiveness. I will conclude right there, and I will be happy to take any questions. Thank you.
Thank you, Dr. Semrett. And I go to our last but not least witness, Ms. Newdorf, who is a patient partner. 5 minutes, please, Ms. Newdorf.
Madam Chair and committee members, thank you for this opportunity. I represent Patients for Patient Safety Canada. We are a non-for-profit, volunteer-driven organization representing those who have experienced harm within our publicly funded healthcare system. We view AMR, sepsis, and healthcare-associated infections as patient safety issues with physical, psychosocial, and cultural manifestations. Patients for Patient Safety Canada is a strong ally in supporting the reduction of AMR infections nationally and globally. We collaborate on research, help to develop national standards and public resources, raise public and professional awareness, and participate in policy discussions. We accept 100% of every request to participate in AMR initiatives. With the family's permission, I will share an experience that illustrates the profound human tragedy behind the science and the clinical, economic, economic and psychosocial burden of AMR. A healthy 70-year-old sustained a simple foot fracture. Within 2 days, she developed severe pain beneath the cast, accompanied by concerning changes in her vital signs and cognition. When the cast was removed, her foot was gravely infected. Sepsis was eventually diagnosed. MRSA, the most common healthcare-associated AMR pathogen, was identified. MRSA is notorious for causing persistent wound infections and, in more serious cases, life-threatening bloodstream infections. What followed was 419 consecutive days of hospital care. She lost her foot and averted amputation of her arm by 2 hours. Sepsis returned, as it does, and ultimately MRSA and sepsis claimed her life. The estimated healthcare costs incurred exceeded $750,000. She never received a prosthesis, but a prosthetic foot can cost $15,000 and potentially $250,000 for a hand. Her husband was at her side each of those 419 days, incurring hotel, food, and fuel costs, and he wasn't able to return to work. Patients for Patient Safety Canada hear stories of stigma and harm, an opportunity for quality improvement. The lived experiences of patients and residents intersect with all 5 pillars of the action plan. This perspective unifies the plan's purpose by centering on the patient, family, and the community. Our recommendations will benefit the public, mitigate the moral distress and burnout experienced by healthcare workers, and reduce healthcare costs. Many civil society organizations dedicated to AMR struggle financially. Therefore, in our first recommendation, we call on the Government of Canada to establish dedicated grants for patient organizations like Patients for Patient Safety Canada and the Sepsis Patient Advisory Council to enable us to continue our collaborative work. The remaining recommendations focus on people-centered engagement and empowerment. Respectfully, a supportive action that speaks to this isn't clear in the action plan. So number 2, strengthen health promotion, infection prevention, and patients' early recognition of sepsis through an equity lens. If $750,000 can be spent on valued treatment, can that same investment go towards community programs that promote healthy choices, living conditions, and bolster our ability to prevent infections in the home and in hospital? Patients and residents do not expect to leave a healthcare facility more ill than when they arrived. It is crucial that high-quality infection control standards are measured and monitored in health and congregate care settings. Number 3, develop resources for patients living with AMR. Provide accessible, high-quality resources for patients who feel at times dismissed, stigmatized, and uninformed about how to live with infections complicated by AMROS. The psychosocial impact on people experiencing AMR infections or living with chronic colonization or post-sepsis is poorly understood and support is needed. Number 4, expand public literacy on AMR and AMU. AMR is technical. Build on our basic knowledge of infection and antimicrobial use. Start in primary education, continue through university programming. Measure the distribution of resources developed by Health Canada and FAC. We can't learn from resources that never reach the intended audience. So measure the public's knowledge over time. Number 5, integrate patient voices in national AMR strategies. The current action plan does not adequately incorporate patient and family perspectives. HESA can play a pivotal role in ensuring that patient and family voices are embedded in policy development, implementation, and evaluation. Thank you, and there is more detail in my submitted brief.
Thank you very much, Ms. Newdorf. I want to congratulate the witnesses. None of you went over time. You were great. Some of you even went under time. So that's something we as parliamentarians can learn to do sometimes, right? Okay, so we now go to the question and answer session. The questions in the round we're doing now are 6-minute questions, but that includes the answers. So remember, 6 minutes for question and answer. I would urge everyone to be as succinct as you can, please. Beginning with, for the Conservatives, Mr. Bailey. 6 minutes, please.
Thank you, Madam Chair. Dr. Lung, is that correct?
Liang. Thanks.
Liang. Canada seems to lag behind other G7 countries in providing access to new antimicrobials. Could you elaborate on specific examples of programs or pilots in other G7 nations that Canada could copy to improve timely access?
I think there are two countries I'm aware of. One is in the UK and the other is Italy. What I know that in Italy is they have access to many of the antimicrobials, but they also have developed a system of oversight so that contracts are negotiated between the government and the manufacturers to have criteria for use and criteria to reevaluate the program based on if there are exceptions to overutilization. In the UK, they have a model based on contracted pricing to incentivize companies to participate through a subscription model. And so there are other examples among the G7 countries, but what's clear is that Canada, compared to these other countries, is behind in terms of our mechanisms for procuring and accessing antimicrobials when they're needed. So we can learn from that through an example is a hub and spoke model where there would be oversight through a more distributed system rather than centralize this through the existing special access program.
Heard about the benefits of a national licensure program for medical professionals. You advocated for a coordinated federal provincial approach, and you just spoke about the hub and spoke model for high volume antimicrobials, similar to malaria treatment. How should the federal government structure its central role to ensure equitable access across provinces, given patient mobility and the rapid spread of resistance?
I think one of the things is to ensure that hospitals aren't the ones facing the budget challenges when accessing these antimicrobials, because it becomes very problematic for various hospitals to deal with this on their own. And so any kind of federal model that ensures equitable access would have to address some of the financial challenges faced by hospitals when trying to access these antimicrobials. A second criteria that I think would be important is that there is accountability that how the funding is distributed, so that the federal government has measures in place to at least some oversight or some accountability when the funding is transferred to provinces if they go by a model that's decentralized.
One last question. I've heard in meetings with various stakeholders that Canada is known for having excessive administrative burdens, paperwork, and red tape. What suggestions would you put forward to improve this reality so that Canadians may gain access to the best health care possible?
I think we need to modernize some of the systems. Currently, with accessing SAP drugs, for example, it's through, if relying on the standard system is through faxing and telephone calls. Then subsequently, there's a lot of outdated mechanisms for tracking. However, it's also important to know that if we're going to develop any kind of improved information transfer system, that we don't follow the mistakes that we have in the past, for example, with some of the information system issues we've learned during the COVID pandemic. I think that reevaluating how data is transferred, both for surveillance purposes and transferred for access purposes, would have to keep in mind some of those major mistakes we've made when trying to develop IT systems.
Thank you.
1 minute? 15 seconds, Burton.
I would like to be under time like our witnesses. So.
Oh, my goodness. Wow. Well, thank you very much. I'm going to go to the Liberals for 6 minutes. Ms. Sidhu.
Thank you, Madam Chair. Thank you, all the witnesses, sharing your insight. My first questions to Dr. Bogosh. Dr. Bogosh, you said that roughly 70% of global antibiotic consumption occurs in agriculture, animal animals compared to about 30% in humans, and you emphasized One Health approach. That resistance can emerge and spread across human, animal, and environmental setting. Based on the evidence, what do we know about how much antimicrobial resistance affecting human medicine is driven by human antibiotic uses versus use in animals?
Yeah, it's a great question. Thanks for bringing that up. A lot. Given that 70% of the global consumption, 70 to 80% is in non-human animals, and we know that there's intimate, interconnected, probably, pardon the term intimate, but there is interconnectivity between animals and humans, and this is how it spreads. And I think if we just focus, if the goal is prevention, and we're just focusing on, family physicians not giving an antibiotic for a viral upper respiratory tract infection, we failed. Okay, we failed. You look at where much of the significant issues with AMR have developed, and it's overseas where antibiotics are being dumped into agricultural animals. And the reason it's being dumped into agricultural animals is because they grow bigger and stronger and have more muscle mass, and you can sell them for more money. Now, there are programs internationally to reduce that, but they're not really enforced. So, I think if we want to look at bang for our buck, if we, coupled with other powers that be, can pull international levers to ensure that there's less use of antibiotics in that setting and the taps are turned off, namely global stewardship programs, that will go a long way.
So you talked about the global stewardship, but approach the best practices are most worth adapting to the Canadian context, whether in surveillance, drug access, or innovation. Where do you see the most significant gaps? We can fill that.
There's really not a silver bullet. It's really doubling down on our efforts with antimicrobial stewardship in a hospital level, but also in an outpatient level as well, where a lot of the antibiotics are used. So, and this is being done. The question here is implementation. But there are best practices and guidelines that are available. One of the issues, of course, that we've already alluded to in some of the earlier conversations is Canada doesn't have a healthcare system. It has 10 healthcare systems. And within each of those 10 healthcare systems, you've got an inpatient, an outpatient, a rehabilitation, a home care system, and none of which communicate. So, these are very challenging hurdles to overcome. Of course, they can be overcome, but again, we have standards to adhere to, guidelines to adhere to, but a lot of work needs to be done in terms of ensuring people adhere to the actual guidelines.
Okay. The other thing you mentioned in your speech, AMR incorporated into defense investment. What specific capabilities should Canada fund under a security lens, and how should the federal government integrate AMR into national security and defense planning?
Oh, I'm glad you brought that up. Yeah, when people talk about health security, we often talk about different things. There's sort of the health side of health security where we talk about, vaccine independence and, creating rapid diagnostic tests and access to, antibiotics. And sometimes we call that health security. But there's also the security end of the spectrum of health security. Preventing bioterrorism events. Okay, we know that there are nefarious actors out there. We know that there are bioterror agents out there. We know that certain countries have developed drug-resistant pathogens like anthrax and botulism. Okay, we know that. We know people have tried to steal Ebola virus, for example, and that's why there's the security around such outbreaks. But what can Canada do? I think, it's extremely important to, first of all, recognize that that bioterrorism is a real threat. And we have a funding mechanism, right? We can appreciate that we are going to spend a lot of money on security. We can appreciate that this is a true security threat, and this can help fund RDTs, medical countermeasures, vaccinations, drug development. It's not like it's completely separate pots of health and security. These are closely intertwined. And, when you benefit security, you can also have cross-benefit to health and vice versa.
And Dr. Liang, in your previous testimony, you highlighted while Canada has a multiple AMR surveillance system, our core problem is a fragmentation, where data is not being aggregated cross-setting in a way it's timely. And today I see that everyone is talking about data which is timely manner, accessible or actionable. You pointed to the particular to hospital surveillance, where reports can be
35 seconds.
out of date, do not support planning. So what should be done in that so we can improve that system?
I think that the systems that currently are in place, we need to look at them again and understand their governance structures along with their accountability for reporting, so that they're not the so that there's some more transparency and understanding why there's delays in data sharing, as well as when they receive the information, what their role is in ensuring accessibility to help inform practices and measure impacts of the program. Right now, for example, if I wanted to understand gonorrhea resistance in Canada as we implement a program in British Columbia, it is very challenging to get any of the data across for British Columbia, but also for other provinces. And that's not for research purposes. This is for program implementation purposes and understanding AMR interventions.
Thank you very much, Sonia. I now go to Monsieur Blanchette-Joncas for 6 minutes, please.
Thank you very much, Madam Chair. Hello to the witnesses with us. Hello to the colleagues here as well. It's really an honor and a pleasure to join you here in this committee. As a new MP to this committee, I certainly hope to work well with you. My first question is for Dr. Weiss. My question for you is as follows. Federal underfunding of prevention and surveillance and in public health in general, is this having a negative effect on Quebec hospitals, on their ability to control and counter AMR? I think that the main challenge is the fragmentation of the system, fragmented across Quebec and fragmented across Canada. As for Quebec, taking that as an example, but this also holds in other provinces, as some of my colleagues have mentioned, there's a kind of dichotomy between the hospital milieu and the outpatient milieu. That's the first point. We know very well, for example, that for outpatients, most of the antibiotics go there. There's also the fragmentation between the human and the animal sectors. That's been brought up. There are temporary or short-term collaborations, of course. I know colleagues at the federal level or even provincial levels who are doing wonderful work in human health and so forth, but these are often university-based, one-offs, in other words, restricted sharing of information and collaboration, leaving us with this lack of collaboration across the entirety of the country and even within the Quebec system regarding the real-life consumption of antibiotics, regarding setting up an IT system that would allow us to quickly see what's being used. I would say that the major problem that we do have in Canada is what is called internationally, the national market. We are a mere 2%, in other words, within the world, and there's no Canadian or Quebec company of size, no sort of multinational that's producing antibiotics. We are often, a subcontractor of someone else who's situated in another country. So it's really up to these foreign entities as to what they want to research, what they want to spend on, and there are even a number of scuffles within Canada to see who's going to get those foreign companies funding them. Sometimes provinces will kind of exaggerate their capacities to get the player to move into their province and so on and so forth. And there's no Canadian player able to take the reins. One of the problems there is that we don't really have a say in the game. Important for Canada to understand this. There was a company that tried to produce the 100 most important drugs in Canada. Should we run into a problem getting them, and it's important to see those sorts of efforts. There is this fragmentation of the Canadian network, surveillance, research, It touches all aspects of the healthcare system. And my colleague, Dr. Wright, mentioned this up there. Are excellent teams, scientific teams working in Canada, but they are fragile. My colleague Bergeron was one of the pioneers in Quebec regarding AMR within our country, but he often works in a silo, isolated, being able to really pierce through to the international market. He would have to work with international colleagues. It's very difficult to get anywhere working just within Canada at this point. I know these colleagues very well. We've worked together, and Dr. Weiss, unfortunately, I must ask other questions, but that certainly is a good answer. I understand what you said, and I've heard that before. We are dependent. Allow me to remind us all of something, a true reality. Canada is the only country in the G7 that has been incapable of producing its own vaccine, COVID-19 vaccine, not because we have no talent, because we underinvest in our talent. From 2000 to 220, we're the only G7 country to reduce our investment in R&D among the G7 countries. So I certainly understand what you're saying. Now you're talking about the large pharmaceutical companies. They were all in Montreal in the early in the century, the year 2000. But if we want to do well, we need our own supply chain. We need a solid innovation sector. And what I see is that Canada is, dragging its feet on that. So very nice. I see what you're saying. Nice to coordinate. But when you've got no investment in R&D, it's more difficult to really draw the suppliers into your area of business and interest them, really. 2 points with regard to our own production capacity, looking at the G7 countries, and indeed our being one that invests the least in R&D, something to correct there. For vaccines, though, the only country that did manage to produce something was the United States. Neither France nor Great Britain or Germany or Italy managed to create vaccines. Everyone depended on the United States' capacity to do so. But all said and done, I would say that if we do wish to up our investments in R&D to improve our GDP, especially in health with the aging population, what Dr. Bogosh said is relevant. There are strategic threats to our capacity to do so. We would need more investment, quick diagnosis, production, logistic capacity, and not merely for vaccines, I would say, for everything that has to do with infection prevention and control, IPCs.
Go now to a second round. The second round is a 5-minute round, but I wanted our new member from the bloc to know that you will be having 6 minutes in this round because we're having a full 2-hour meeting, and so in 2 1-hour meetings you get 2 6s. So the committee all decided to be very cooperative, and you are going to have a 6-minute round in the second round. Thank you. So I'm going to go to the second round. Ms. Conans from the Conservatives. For 5 minutes, please, Eleanor.
Thank you, Chair. My first question is to Dr. Weiss. You touched on and you talked a lot about the overuse of antibiotics, and but as you know, and you mentioned that they're sold all over the counter in other countries, and since they're given out less and less here in Canada, people when they travel, they stock up on antibiotics because they can buy it, and who knows, some of it may be counterfeit, but they're stocking up and bringing it back. What do you say about that, and how much of that is an issue?
In fact, this is a very interesting question that you're raising. How much is it an issue? We don't really know because we don't monitor these type of things. But definitely there are people who are probably bringing back on a volunteer basis or not on a volunteer basis, sometimes because they simply bought antibiotic outside of the country and they're bringing them back here. So that's definitely an issue. So the issue we have in Canada is because we are in this global village in terms of antibiotic use. And I always tell people, infectious disease is the only specialty in medicine when whatever happens at the other side of the world will have an impact on you. I tell my patients, if your neighbor neighbor has diabetes, it's very sad, but it's not going to impact you directly. If your neighbor has Ebola, the first thing you're going to ask yourself was when was the last time I saw my neighbor? Because obviously infectious condition can be transmitted to people, and whatever happens, in Asia, African countries, South America, Europe, whatever, you can bring back your resistance with you. In fact, there was a study, I think, done in Switzerland and another one in Sweden where they decided to swab tourists who went abroad and came back and just ask them to give like a stool sample, asking them to make sure that they were healthy and nothing happened during their trip. And about 25% of these people were carrying resistant bacteria in their gut. And that tells you, and obviously these bacteria are not being declared to custom officers when they come back, but they travel as a Trojan horse entering the country and potentially creating issue. We see this, for example, in young, healthy women coming back from the Indian subcontinent in our hospital every day with simple infection like a cystitis, a bladder infection caused by sometimes a very resistant antibiotic where we have to give intravenous antibiotic with all the logistical consequences, the cost, etc. So I would say that the flux of bringing back antibiotics into the country is maybe marginal. I don't know the answer because nobody is looking at this carefully. And yet it could, yes, be a problem in certain things. But I think the fact that people are traveling and bringing back resistant microorganisms is also part of a biggest picture.
Thank you. That's really, really interesting answer. My next question is for Kim Neudorf. Kim, how do you see the present ability of the federal government in acting with urgency to bring in or develop new medicines to Canada? Is it still too bureaucratic in your point of view?
Thank you, Madam Chair. Based on everything that I've heard from the experts and people around the panel today, it does seem to be problematic. It seems to be cumbersome. I was just reading recently about gonorrhea resistant medication, AMR. And so there's something that exists currently in the U.S. A different medication doesn't sort of fall along the antibiotic line, but that is ready and available to them, 2 different medications. Whereas here in Canada, what I understand is that we have increased the dose of the antibiotic in order to try and curb this resistant organism.
Okay, thank you. Sorry to interrupt you. I think I only have a little bit of time left. I just wanted to follow up with a question about, I represent a region of the country where patients' access to healthcare is not consistently available. So we literally have ER rooms suddenly close at least 1 day a month. And you're talking about patient safety issues in everything, including AMR, health, infection prevention. Can you tell me, what do you think about the danger of having ERs closing throughout, my region and throughout the country?
Yes, thank you for that question. And I think it is very much a concern, and I think that it drives some of the public's misuse of antimicrobial medications, because access, we can look at access from many different angles, not just crowded emergency rooms, but it will push us to stockpile medications or to hoard medications and only take part of those medications so that we can perhaps use them when we think we need them, put them on our shelves, use them when they're 5 years old. Because
Ms. Neudorf, can you wrap up, yes, please? Thank you.
Because we don't want to sit in an emergency room for 5 hours. And then, of course, other issues around sepsis as well, where we maybe are sitting at home too long when we need that antibiotic for that particular issue. So thank you so much.
Now we're going to go to Monsieur Eyolfsen for 5 minutes, please. Doug?
Thank you, Chair. Thank you, Chair. Thank you, everyone, for coming. Dr. Bogosh, you spoke about this. regarding how, it's, as you said, 80% of antimicrobial use is in animals, and how a lot of that is it's put in feed for growth. Now, the question that I've asked this in previous times, I've never been able to get a really solid answer about this, is that, in the human setting, at least in Canada, you cannot get antibiotics for human use unless you see a doctor, you get a prescription, and the doctor has diagnosed an infection, presumably, and prescribes the antibiotic, and then it is dispensed to you. What is the mechanism that there is not this control on dispensing antibiotics in the agricultural center? How are they getting a hold of these when it is so restricted in human use?
Yeah, it's a great point. For starters, I'm not going to comment on veterinary practices in Canada. I just don't know the answer to that. But globally, as one of the other speakers mentioned, you don't need prescriptions. These are readily available, they're commercially available, and they're used en masse in agricultural settings, and also in human health settings as well, where you can literally walk into a pharmacy and write something on a napkin and give the pharmacist the whatever you want, and they'll sell it to you. I mean, but it happens not just at an individual level. It sadly happens at scale in several Asian countries, African countries, and not so much in North America, where we have tight regulatory controls. Same with Europe, but as we mentioned before, the drug resistance develops and people travel through trade. We see the spread of dangerous antimicrobial organisms. One, for example, NNDM1 started in India, MCR started in China, and they spread around the world.
Okay, thank you. Yep. Sorry, it keeps cutting off. Yeah, thank you. Yeah, no, what I guess in the Canadian perspective, is this still permitted in Canada, or have they restricted this practice in Canada?
It's tremendously restricted in Canada. I don't know all the details of the restrictions, but I know that we're not pouring antibiotics into livestock in Canada.
Okay, thank you. Yeah, that was, yeah. No, that is good to know. Yeah, that was an important part of the question. Are there, to your knowledge, are there international bodies that are, trying to get a global strategy on this? Is the World Health Organization working on this? Is the UN working on it?
Yeah. So there was a program called GLASS, the Global Antimicrobial Resistance Surveillance System, that is run by the WHO. The CDC runs a program called the Global Antimicrobial Resistance Laboratory and Response Network. But as we've seen over the last 12 months or so, the WHO has been significantly impacted by major funders pulling out, and they're just not able to run the same programs to the level that they were before. They're in a bit of a remodeling mode because of the significant funding crunch, and certainly the United States, the CDC, is having significant changes as well. So a lot of the global funders and the global players are these programs aren't going to be running as effectively as they once were, despite this being a growing issue.
Okay, thank you. Do you know what the change in funding, particularly from the United States, was? Like what proportion of their budget on these programs was when the United States was funding the World Health Organization versus their currently where they have stopped?
Well, they just pulled out. It was announced they pulled out of the WHO yesterday, and I believe that was about $100 million a year of funding, which is pretty significant. The WHO budget is not that big considering its enormous mandate.
Yeah.
They don't have enough money at the best of times, and having a major donor pull out is very problematic for global public health.
All right, thank you. Dr. Leung, very quickly, you talked about vaccines, and we know that viral illnesses like flu, you can get secondary bacterial infections. Canada has a tremendous problem with decreased vaccine uptake. Given that setting, that there are secondary bacterial infections often, would you say that Canada's decreased vaccine uptake is contributing to AMR?
Overall, when you have a decreased vaccine uptake, depending on the types of vaccine, definitely they will contribute to AMR. So one specific example is with the Streptococcus pneumoniae vaccine, which is for a bacteria, most common cause of bacterial pneumonia, but leading to invasive infections. The reason why the uptake there is low is not because of issues necessarily related to vaccine hesitancy, but it's about how public health distributes the vaccine in each of the provinces. And when you look at opportunities for vaccination when people interact with healthcare systems, it's not just in the community. And so the big gaps are in hospital vaccination, hospital-based vaccination opportunities, and how that ties into the spectrum of care as individuals have problems with access, even if they want to get the vaccine. So improving access is I think, one of the important things that need to be addressed when thinking about vaccines and AMR.
Dr. Leung, I'm going to ask members to please remember that when you only have 15 seconds left, please try not to ask a difficult, long answered question. So I'm going to go to
Thank you very much. Let me continue with Dr. Weiss. In his report, Changes on the Horizon, he underscored that AMR is the first cause of death around the world at present. So we know that it's already an issue affecting access to food, that it costs more to care for humans and for animals. Because of AMR. Now, you also mentioned fragmentation. I've got 82% of antimicrobials sold in Canada go to animals. So, of course, the proportion of them for humans is much less. So I'd like to hear more on that, and I'd like to hear your analysis of that situation. The use of antibiotics for animals is in an economic context. It's really to ensure that the animals grow more quickly, weigh more quickly, so that they can be sold at a higher price. And there's certainly a benefit to that use. And then, of course, we could think through what type of agriculture we wish to promote. But if you've got a million chickens and you're not providing any antibiotics, then you could very quickly trigger an outbreak, or one single one could trigger an outbreak and you lose them all. So there's got to be a balanced use of antibiotics. Luckily in Canada, there is a good level of regulation such that animals are taken off antibiotics before they go to slaughter. So if you're asking yourself whether you're eating antibiotics, likely not, given that antibiotics have been ceased before the animal has been slaughtered. So all that taken together, there is, a certain level of structure here in Canada. There are countries such as Denmark that have tried to push things further to reduce the use of antibiotics in agriculture, particularly for pork. They have some level of success, not total success on that. So yes, indeed, many antibiotics and a good deal of antibiotics is used for animals. And, of course, for humans, the aim is therapeutic. For animals, it's an economic aim, other than for pets, of course, cats and dogs, that also receive antibiotics for therapeutic reasons, on therapeutic grounds. So, of course, there would be some improvement we could make in the use of antibiotics for animals, but the world situation is difficult to contain, to control. There's also the use of antibiotics in aquaculture. If you go and buy shrimp from some areas of the world, a good deal of antibiotics could have been used to raise those shrimp. Do we have full control over that? I'm not sure. We'd really need a bit more information on that to understand how much antibiotic is being imported, if you wish, into our food system in this way. If I may, Dr. Weiss, I'd like to pick up on something that you certainly have knowledge of, what goes on in a hospital. When a resistant infection no longer responds to treatment, of course, we have to hospitalize patients longer, and this takes a lot of resources. So is AMR already contributing to the pressures on the hospital network of Quebec due to this? Certainly it is, given that the demography, the population is aging, people need more medical help, and as older patients as well, across all provinces. When we keep people active until the age of 80, even with dialysis and so on, with all the potential for pathology that's linked to dialysis. Same thing for people going through complex surgeries or chemotherapy. And there is an effective antimicrobial resistance on all these treatments. Studies show this to be the case. And this means that it costs more to treat these people and costs more to provide them with antibiotics that work. So the risks of antimicrobial resistance for the most vulnerable patients in this system are very real. If you take, for example, young children in good health, they may have ear infections. They're resistant to some of them. They've got a microbe that's not responding. They can take another antimicrobial medication and likely it'll work. But if you've got an older patient who's got resistance, it's more difficult to treat them. Dr. Weiss, what you have mentioned is prevention, and that's very important. I have the impression that we are sacrificing prevention given the types of choices we are making, how we're spending our money. So clinically speaking, don't you think that prevention and surveillance is what works best? Yes, of course. Prevention is always difficult to invest in. It's especially if you've got a system that's already running on empty. Often it's seen to be an expense rather than an investment that is obviously paying off. You can't measure the effects of prevention. Same thing for vaccination. It's an attitude that affects vaccination. It sometimes takes a while to vaccinate certain groups of patients because you can't necessarily tell whether it's saving money or not down the line. So, indeed, we should invest in prevention.
Now I'm going to go to Mr. Viersen for 5 minutes, please, for the Conservatives.
Thank you, Madam Chair. I think this, given I was reading Mr. Wright's bio, my series of questions is likely directed towards him. Mr. Wright, my questions are a bit about prevention, but then also the treatment side of things. Our instincts have been over the last number of years to pursue hard surfaces, plastic, stainless steel, these kinds of surfaces that we now are discovering that these bugs can actually live on for a very long time. But we've abandoned other products, say wood, silver, brass, those kinds of things that we are discovering that actually are very antibacterial. So I would like some comments around the use of those materials in, say, building of hospitals or things like that. And then I represent about the quarter of Canada's beekeepers, or a quarter of Canada's honey production, not beekeepers, but Canada's honey production. And my beekeepers say that they have a solution to some of these superbugs, and that's bee propolis. And so I'm just wondering if you've got any comments around, is that being used in medical settings, and is it being, are the beekeepers telling the truth when they tell me that they have a solution for some of these superbugs? Mr. Wright, floor.
Well, thank you for that. Let me dodge the last question first and say your beekeepers no doubt are telling the truth, but I don't know a lot about those compounds themselves. I know that bees as social animals actually and are highly susceptible to infection. And so they very often produce a lot of very interesting compounds, or they're associated with organisms that do produce interesting antimicrobial compounds. And the area that I know the most about is leafcutter ants, where they're actually, actually harvest and embed in their skeletons antibiotic producing bacteria so that they can protect themselves. So I would not be surprised that your beekeepers are right. I don't whether or not it's a solution for non-bees. I couldn't comment. With regard to your first question about surfaces, it's really important as you know. So bacteria have several different we think of bacteria as just growing in solution and they divide and then they divide and they divide, but a really important physiological lifestyle of bacteria is something called biofilms. And in fact, probably most bacteria in the world are found as biofilms, and these are embedded in like sugar matrices that form. You would think of it as kind of as slime almost. And those they bind to surfaces, and when they bind in these surfaces and they enter these physiological states, they're highly resistant to antibiotics. Very challenging to get rid of, and they can come off. And this is why you oftentimes get chronic infections due to, for example, catheters that are inserted because these bacteria grow as biofilms around these plastics. The challenge of using other materials like wood and certainly metals like silver and brass have well-known antibiotic properties is really one of practicality. It'd be hard to think of how you could implement that, for example, in a lot of devices that are indwelling devices that are used in humans. So I think it's in many cases it's much easier just to pull them out and toss them out. But I will, make the point that many times, like important indwelling devices, like artificial joints, are made out of heavy metals like titanium, and for reasons that they have these inherent antimicrobial properties. So, and then to wrap up, I think the first part of your question, certainly these there are different surfaces always being looked at as sources of to prevent infections. But also balancing out the cost, it's always a significant challenge, I think.
Is there 39 seconds? What's that?
39 seconds.
39 seconds, he says. Okay, I'm just I'll go back to Mr. Wright a little bit, just around public perception. Some of it is just about, we think about, a wooden surface is probably dirtier than a stainless steel surface, and maybe there needs to be some change to our thinking around those things. Do you have any comments around that?
I honestly have no expertise in that to be able to actually say that for sure. I know I used to work in a kitchen in a hospital as a high school.
Could you point us towards somebody who would have some expertise in this?
Well, given that
you'd have to find
out of time, Mr. Pearson, I think we could see if somebody wants to throw that in their question next time. So I now go to the Liberals. Ms. Jasek, for 5 minutes, please.
Thank you so much, Madam Chair, and thank you to all the witnesses. Dr. Wright, I'd like to start with you. You have talked about push-pull incentives. Specifically, I would like to drill down a little bit as to the role of the federal government. One of the suggestions we've heard today was that CIHR form a specific stream related to AMR. Is this something that you would see on the push side in terms of advancing research as a good recommendation? And then secondly, on the pull side, could you be more specific as to what you would see that the federal government should actually do on as an incentive to encourage development of new antibiotics?
Yeah, thank you for that. That's something I actually know about. So an increase in the budget to the CIHR for the fundamental upfront discoveries is a classic push mechanism. We're going to push the science. We're going to make this kind of science attractive to the best, youngest scientists that are available for us. So that would make a huge impact. On the pull side, this is where we're trying to actually pull discoveries into patients. And that's usually at the level of the best people who know how to do this are large pharmaceutical companies who know how to make drugs, can do this at scale, have the facilities to do this. What we have to do is make it profitable for them to do it. We do this in vaccines all the time, right? We promise vaccine developers that we're going to buy X amount of doses. And so there's no mystery to the vaccine developer that they're going to get their return on investment. We don't do that with antibiotics, and we should. And other countries are doing this: Norway, the United Kingdom, and and hopefully Canada too going forward. It's especially a challenge for us because we have such a small market. We need to get these drug companies excited about selling their products in Canada because it is so small. But if they had a guaranteed income, they would do it.
Thank you. Dr. Semret, very involved, obviously, in surveillance and stewardship and so on. One of the recommendations we've heard at this committee is that we should look more closely at long-term care facilities for both stewardship and surveillance. We do have, as has been pointed out by many of you, a very fragmented system in terms of data collection across the country, within countries, between institutions and so on. But would you see it as an important source of information if we look more closely at long-term care facilities?
Yes. Sorry. Yes, absolutely. I think we need to expand definitely beyond acute care hospitals. In my remarks, I think what we should recognize is the fact that the reason we're not doing it in the community or long-term care facility is because of the resource-intensive nature of performing effective stewardship interventions. But if we start coordinating to make some of these definitions more pragmatic, and if we have better ways of implementing stewardship, I believe it will be very organic and very natural for these good practices to be deployed across the spectrum of healthcare institutions. I think there's many things that we can do before forcing, sort of mandatory stewardship programs in settings that are poorly resourced.
Any time left, Madam Chair?
Yes, you've got 1 minute and 19 seconds,
Excellent. Dr. Bogosh, we've heard the tragic story from Ms. Neudorf related to sepsis. I think most of us have been aware of MRSA, VRE, Clostridium difficile, and so on as being very difficult infections to treat. So in your experience as a clinician, what kind of progress are we making? Are we lacking, again, some appropriate new antibacterials, antimicrobials? And what is your experience around some of these very tragic situations?
Thank you. Yeah, it's very challenging. I mean, anyone who practices hospital-based medicine, either as an infectious disease physician, a general internist, a surgeon, an intensivist, you're going to see these every day. We see these every single day. Much of the time we have the existing tools, but when we don't have the existing tools, we have to go through the SAP program, which is extremely cumbersome, and it actually delays care. There are drugs that we just don't have available to us that we need. Sadly, we're needing them more frequently, and it's easy to say the SAP program doesn't work, is cumbersome, is outdated, but I think it's time to actually implement something better. And it would be a good idea to get smart people in the room to sort out a much more efficient mechanism to gain timely access to antibiotics that we don't have available to us readily, that we're needing more and more.
I'm going to go to one final round, and I will begin for the Conservatives with Mr. Major for 5 minutes. Please, Dan.
Thank you, Chair. I thank you for all the witnesses for coming here today. In October 2023, the Auditor General released a report examining the federal government's approach to antimicrobial resistance. So one theme identified by the Auditor General is that while the federal government recognizes antimicrobial resistance as a serious public health threat, the National Action Plan does not include clear targets, timelines, or accountability mechanisms. From your perspectives, what are the risks of responding to antimicrobial resistance without measurable goals or clear accountability outcomes? And I'll start with Dr. Bogosh.
Thank you. Great question. Yeah, we have to measure it. We have to have outcomes, and we have to measure them. We have to know how we're doing. And I think one of the challenges, though, is, and I mentioned it earlier, is we can do everything right, and we can still get throttled from AMR because of what's happening elsewhere in the world. But that doesn't mean we shouldn't be acknowledging that this is an issue and setting up programs to better measure it and to better control it. And, the measurements don't necessarily have to be morbidity and mortality, which of course are important measurements. They could be, how many programs have you set up? Do you have, what's the timely access to drugs that might not be available in Canada? Training programs. And I think those are very important issues that obviously need to be implemented, but also we have to measure how we're doing.
Dr. Semret, I believe you made some comments around feedback, so I think I would like to hear from you on this as well.
Yes, I think the issue of what we measure is a really important one. We have been in acute care hospitals, we've been really focused on process outcomes, what I would call process outcomes, what we're doing, how many antibiotics, how many prescriptions are we reducing, and what is the quality of the prescriptions. And we have been less focused on patient-centered outcomes, which I think would be an important incentive for hospitals and for healthcare in general. So patient-centered outcomes, I think the antimicrobial stewardship is really about, as has been said by multiple people, is really around patient safety and health system sustainability. So the success of our stewardship efforts should be judged not just by the reduction of antimicrobial use or even in the improvement of prescription quality. It should really include clinical cure. And you'd be surprised, but we actually don't systematically measure outcomes from infectious diseases. Not anywhere, not in acute care hospitals, not even in the intensive care units of our hospitals. So I think that should be an incentive that should be sort of created, and where acute care hospitals should start measuring this systematically. And this could be rendered much easier by IT support. So Victor had mentioned that, several of my colleagues mentioned that, but electronic prescribing systems across settings would facilitate, the development of structured data sets that would make those, not only the processes more efficient, but would give us very useful metrics.
Thank you very much. And with that, I'll hand my remaining time over to Ms. Konatz.
Thank you. Yes, I'd like to make a motion, take this time to make a motion. The motion is that given the order and council appointment referred to the Standing Committee on Health on December 4th, 2025 by the Board of Directors of the Canadian Centre on Substance Abuse, the committee invite all Governor and General Council appointees currently serving in the Canadian Centre on Substance Abuse to appear for one meeting to discuss their work before February 13, 2026. And I just want to add that this is a new committee and we haven't met them. I think it's important that we all get a chat with them. If for some reason we need to move the meeting a week later than February 13th, I know we're running out of time a bit, so if we can do that, if we want to move that by a week.
Sorry, Kelena, what did you just say about a week?
The motion says that we need to discuss their work before and meet them before February 13th, 2026. But that's the original motion I made. But if we need to extend that by a week, that'd be fine, just because I know that we've got a lot on our plate. So we'd like to. I think it's a good idea for the committee to meet.
I just wanted to ask everyone: do you have that motion? In English and French, it was moved a while ago, but she's
December
now amending it somewhat. Here we go. I'm going to read the motion slowly. It's that it was moved on December the 10th, that given the order in council appointment referred to the Standing Committee on Health on December the 4th by the Board of Directors of the Canadian Centre on Substance Abuse, the committee invite all Governor and Council appointees currently serving in the Canadian Centre on Substance Abuse to appear for one meeting to discuss their work before February the 13th. What Ms. Konatz has just added is she's prepared to extend that by 1 week, given that we have a lot on our plate. So you have a motion on the table that had been duly circulated a while ago. So, Maggie, to the motion.
Can we suspend for a quick second so we can take a look at the...
Sorry,
May we suspend the meeting?
Sorry, I just took this off.
Yeah,
Sorry.
Chair, thank you. May we suspend the meeting for a quick moment so we can examine the motion? It was tabled a while ago, so we just need to take a look. Yeah.
Suspend.
Thank you.
And now, I will entertain discussion on the motion. Go ahead, Ms. G.
Yeah, so we will. Do we need to change the motion, Chair? Because I think the date we just need to update the date to up and.
She said a week.
A week. No, we agree on another date, February 26th.
I'll
Have
agree.
you all agreed on that?
I do.
Okay,
Yeah,
well,
we-
that's good.
Okay. So do we need to change any of the wording?
We should just add then, so we say, instead of before February the 13th, we say their work on February the 26th. Before, okay, not on, before. February the 26th, 2026. Before is better than up to. Okay, so we have a motion, and do you want me to read it? You all have it? You all know what it says? Is there discussion on the motion? No? Then I shall call the question. Is there no further discussion? We can call the question on the motion? Go ahead. Do you want to
Clerk's
just...
got everything that she needs?
Yes,
everything
yes.
set?
Do
Okay.
we just call the question, or do you
Sure.
want
Just
a
you
recorded
see.
vote?
You see, it's good.
Just call the question. Those in favor? Those opposed? The motion is carried. So there you go. We can move on now. So there you go. That motion is carried. And we can move on now to finishing up the round that we were doing. And I think we are now going to Ms. Shi for 5 minutes, please, for the Liberals.
Thank you, Chair. I want to say Happy New Year to everybody. Before I get into the question, I want to thank Luke and Adrian for their work on the committee last year, and welcome our new member Maxime to our committee. Looking forward to working together. And thank you to all the members for attending our very first HESA meeting in 2026. Thank you for starting us in the right way, giving us really pertinent information on this topic. So I want to start off by the first question is to Dr. Wright. So in your testimony, you mentioned about the research environment in Canada and how some of the challenges you experience or some of the gaps that you see. I just want to ask if you can outline that a little bit more and what you see in other countries. Give us a couple of examples that are working well that we can really learn from.
Yeah, sure. Thank you very much for that. So let me first say that there'll never be enough money to do this. So I get it. And I know it always sounds like we're whining about trying to do this, but I think what I'm deeply concerned about is this is such a massive public health problem. It's only going to get worse. How do we incentivize young people to work in this area if there's really almost no chance? You might be much better off going to Vegas to get a grant to support your research in AMR these days. Just because it's funding is so tight across all the healthcare sectors, and there's really no dedicated funding for this within the traditional CIHR mandate. So my suggestion would be to try and find a way, not to steal money from other people, but to try and find a way to fund AMR research directly through the CIHR and not lump it in as part of all of microbiology. Other places do this much. So I would have pointed to the States a year ago as being better than this, but it's obviously who knows what's going on there and what's going to happen. And I think, if anything, this is a tremendous opportunity for us because it's chaos for the research community south of the border. And there are opportunities to repatriate some outstanding Canadian scientists who are away. But Europe is doing this quite well. There's a lot of dedicated funding in a number of European countries that really emphasize this. I'm thinking of Germany, I'm thinking of the United Kingdom, thinking of France, who have made this a priority and are funding fundamental and applied research, right? They're actually funding not just the curiosity-driven research, but how do we solve this problem? How do we incentivize companies, small companies, to get into this? How do we make sure that medicines get to patients in the future? So there are lots of lessons out there to be learned, and I think we could take a page from Europe in particular in this area.
Thank you, Dr. Wright. And my next question may be to a few people on the panel. I just want to see, we've heard of, from witnesses, the data is fragmented. There are some disjointed practice and approach. But I want to sort of, pick your brain on what are some of the innovations that you see in this space in Canada. And maybe, we can cover a couple of areas. Everybody is from different regions. Dr. Leung's from BC, Dr. Wise is from Montreal, and Dr. Bogosh is from Ontario. I just want to maybe each can give a quick summary of that.
You have 1 minute to do so. Quick summary.
20 seconds each. Yeah, Dr. Bogosh.
Sure. In 20 seconds, there's something really interesting called PHAGE, P-H-A-G-E, where you use viruses to target bacteria. It's been around for ages, but there are people who develop this here in Canada, and it's used to treat the most drug-resistant organisms that don't have antibiotics that are available for them.
Thank you. And folks online?
I'll just maybe go for Quebec. I know that, Vichy Quebec with Michel Bergeron, when he was at the helm of it, developed a lot of molecular-based diagnostic tests to look for antibiotic-resistant microorganisms. They have been subsidized by CIHR, and they're doing a great job in that field, I think. And they were, in fact, at one point bought, quote, by multinational companies for their innovation.
Thank you. Do we still have time, Chair?
Yes, well, you asked everyone to answer. I think, Dr. Leong, do you have anything to add? Or you cool?
Yeah. So from the Vancouver side, I think one of the innovations is more of a community-based program that was started by the BC Center for Excellence in HIV/AIDS, which is the treatment as prevention approach, using that to address syndemic conditions like opioid use disorder, bloodborne bacterial sexually transmitted infections, as well as other social conditions, using that treatment as prevention bundle where we have measurements through the cascades of care would be something that we can borrow from how they've managed HIV/AIDS.
Anyone else wanting to answer this quickly? You have, well, we've gone over time, so I will just say thank you. We'll move on. I'm going to go to Mr. Blanchette-Joncas for 2.5 minutes, please.
Merci, Madame la Présidente. Alors,
Thank you, Madam Chair. So I will continue with Dr. Weiss. If you have stable funding, what would be the measures you would immediately want to set in to better control antimicrobial resistance in hospital settings? First, an integrated IT system much broader than the one we have now that would allow us to gather data in real time. Secondly, I think we need to work with communities. We're hearing a lot about hospitals, but keep in mind that most antibiotics are used by outpatients, and we're not measuring all of that. So we need to improve education and information gathering among family physicians, for example, and, for example, pharmacists who also have a right to prescribe. And we really need to see what's going on outside the hospital, in brief. So IT, that's the first thing, being able to share information quickly. Second, basic research, integrating the teams that are now working alone in silos. Often these are very good teams that are able to unearth important facts and material, but are working in isolation, aren't well integrated across Quebec or across Canada. So we need to link all these systems. We also need to sell internationally the very capacities of our R&D teams, really promote our research outside of Canada in order to leverage foreign investment in Canada. Also, if we could bring foreign talent to Canada, why not? This is something that we should make easier. Dr. Weiss, can we say that today the Quebec healthcare system is forced to pay more for problems that could have been avoided had we invested more at the outset? Well, look, we're all paying more across Canada. I'd say one of the main problems we have is that we're sort of stuck in, between a rock and a hard place. You've got this sort of therapeutic system, drug companies, mostly American, that tend to invest mostly in the United States. That's where the market is. And then you've got other companies investing in Europe. And then you've got companies that invest in emerging markets, India, Asia, and so on. And Canada is kind of left aside, given that our market is so small. So we need to use the synergy of our talent to prove to the world that even though we are a very small market, we can play like any other player. We can provide new findings and new drugs that it would be difficult to get elsewhere. So we need to really emphasize our plus value and do so by creating, backup structures, data that could allow us to sell all of this.
I'm sorry. I'm going to go to Mr. Bailey for 5 minutes for the Conservatives.
Thank you, Chair. Dr. Wright, many trainees leaving Canada for a stronger biotech opportunity abroad. You've indicated that there's opportunities possibly to start recruiting back to Canada. Do we have room in our labs and the universities to accommodate more individuals?
So thank you for that. The short answer is yes. We should never leave talent outside of the country. So if we want this, of course, we need the resources to be able to do this. Right? It's challenging enough as it is. But we have a tremendous opportunity right now to be able to expand our critical mass in this area. Even if we just if we brought Canadians back home who are working over there, but it won't happen. It can't be a zero-sum game. There has to be more investment to be able to make that happen. But it literally is an investment in our future.
Thank you. Some provinces now are allowing pharmacists to prescribe. Do you feel that this is leading to overprescribing?
I don't think there's any data to suggest that that's the case. So I think most healthcare workers, pharmacists, like physicians and nurse practitioners, are incredibly savvy these days about the challenges of resistance. I think it's important to monitor this, and as my understanding that that's happening in real time. I think some of my colleagues on online probably, and Dr. Bogosh may have more information on this than I do. But I do think this is not like 20 years ago. We understand this problem, and I think if you can decrease the pressure on physicians and hospitals by engaging pharmacists to be able to deal with this, I think that's overall a positive.
Dr. Bogoch, did you want to say any comments?
Yeah, that's a great point. And, task shifting has been implemented in different parts of the country. I'll give you a tiny example. Lyme prophylaxis. You get bit by a tick, rather than waiting for in an emergency department or going to a family physician that you might not even have access to. Many pharmacies have the authority to prescribe an antibiotic, doxycycline. And they have very clear guidelines of what drug to use, how much to use, and what time frame to use it as well. So, yeah, I think task shifting can certainly be expanded, but to the point that other of my colleagues have made, it's got to be done very carefully in order to not make this issue worse.
In Alberta, we have gone to a new MR system called Connect Care, which allows our doctors in all the different specialties to communicate with the hospital. And of course, our patients now have access to their own medical records. I'm wondering if this type of MR system is implemented in more provinces. I don't ever see all the provinces being connected, but can we monitor the metrics better in Alberta? Can you look at data that way because everything is shared?
Yes, that's a very smart system. And one of the issues we have in other parts of the country is that there's fragmented electronic medical records. When it's all connected, the outpatient physicians know what the inpatient physicians are doing. They know what's happening at the rehabilitation center, at the long-term care facility. It's brilliant. There's less redundancy. There's streamlined care. And yeah, there's going to be many positive knockoff effects, including probably better care for infectious diseases, which would likely mean less use of antimicrobial agents and less pressure to develop antimicrobial resistance.
And I overheard that you travel through many provinces. Have you seen a system in other provinces similar to Connect Care?
In Ontario, we have a program called Connect Ontario. It's not perfect, but it's pretty darn good, where you can see most notes written by different hospitals. You can see lab work and even some basic pharmacy information and radiography. But it's far from comprehensive, but it's a hell of a lot better than what we had before.
Okay. Because in Alberta, of course, we had 3 systems and we went to 1, and we're not even there yet. We're $1 billion in, and that's why I say that it'll never be a day that all provinces are on the same MR system. But Ontario, you say, has a system. What about British Columbia? Do they have
12 seconds.
Okay, well, I won't get an answer. Thank you.
In British Columbia, we have PharmaNet, which has all the community all the community prescriptions of medications.
Good. Thank you. That's it for that. And I will now go to the final round, and that is for the Liberals, Mr. Ailson. For 5 minutes, please, Doug.
Thank you, Chair. Yes, Dr. Leung, you mentioned, you talked about, interoperability, or a fragmented system. And I know that within provinces, we're getting better at interoperating. When I work in emergency in Winnipeg, I can see on the computer the emergency record if they've visited any emergency department in Manitoba. and family doctors can get automatic transmission to their own EMRs if their patient is visited. However, between provinces, I know we don't have this. I live in Manitoba. 3 years ago, I had bypass surgery in St. Paul's in Vancouver. Long story why that happened. But when I saw a cardiologist later, and the office asked for that we needed to get my discharge summary and angiogram, they asked if I could fax it to them. And the only reason I had it available to me was that they gave me the photocopies in Vancouver to then take home on the plane. It seems absurd in this day that there would not be some sort of mechanism that you can have this interoperability between provinces. Would you not agree that an interoperable national system could happen that is, equivalent to what is being done within provinces?
So certainly, there are different types of interoperability that I'm aware of. One specific thing is you don't have to have the same medical information system or laboratory information system to share information, as long as the data system that they're using meets a certain level of coding for sharing and interoperability. That is sufficient. Of course, it requires data verification and validation aspects, but these type of approaches already exist. It's just the mechanism and how it could be implemented in Canada is the problem, not necessarily having an agreement that every medical information system across Canada has to be the same.
Oh, certainly, yeah. And as you say, yeah, and I understand that they couldn't be the same. But what would you say is, from what you're saying, they have the capability of doing this where, the information could be shared. They obviously can't today. What would you say is the main barrier to creating this sort of, ability to share in real time this information electronically, which could help with, as you say, surveillance and all these other things we're talking about today?
I just mentioned one of the barriers. One of the barriers that is often brought up is privacy, data privacy. Even when you look within a province, there are data privacy teams within each hospital network. And to share information, sometimes you have to go through multiple teams. So that is a real barrier that we face in trying to access information that's already available.
All right. Thank you. Dr. Bogosh, do you have anything to add to that?
No, I thought that was pretty comprehensive. Yeah.
Okay, thank you. Dr. Weiss, any other on that term, on that point, anything to add of possible solutions or the barriers to preventing this interoperability and sharing between provinces?
There are many, obviously. We have a system in Quebec which is not working so well called the DSQ. It's a very limited system compared to the other provinces. Interoperability would be probably very interesting. However, as my colleagues mentioned, ethical issues are probably in. The second thing, if we want to be optimistic but not too much, at least if we can share certain things that can be integrated. We don't have to integrate everything, and it's going to be probably a lot easier. So from an antibiotic, for example, resistant perspective, should we integrate data from microbiology laboratories, for example, so we can connect and share some information? Can we look at certain metrics, for example, outcomes in certain infectious conditions? Let's say sepsis, for example. Should we look at mortality, sepsis mortality throughout the country and say, can we have comparable between provinces? Or, for example, outcomes for hospitalized pneumonia, mortality rate, antibiotic use, etc. So I think we should have to try to focus on certain things in terms of the Canada-wide structure. That would be probably more feasible, less costly, and probably more effective in a very short time.
Thank you very much.
Thank you very much. That's my time.
And I just wanted to ask one question. If you had non-nominal ways of communicating patient data, would that help the privacy issue?
Yes.
Who said yes? Did Victor say yes? Yes, Victor.
Yeah, there are different approaches now in our data analytics team and exploration of those approaches. One is the data management through this process called federated data, where the data doesn't have to leave the process where you can still link and unify data for access in multiple locations without giving up the data and where the data is stored. So I think that the consulting data management experts would provide you with a bit more kind of clarity on how that would work.
Thank you. I just had one more question I wanted to ask. I know there has been an idea floating around in Canada about not trying to reinvent the wheel, but looking at European or other countries' data on drugs and information and research and sharing it without having to go through the thing of doing it ourselves. One of the big ones that was discussed here was getting things onto SAP and looking at clinical trials, et cetera, et cetera. What do you think of that? Because I know some people have felt it was a terrible thing to do. What do you think about it? Dr. Wright?
Well, I think that I'm a scientist, so I believe in looking at data, and I look at everyone's data, and I think if there are deficiencies in that data, then we need to add more of our own to it. I do think that there's a fair bit of effort trying to harmonize these efforts. Why go through all the same kinds of studies in Canada that have already been happening, say in France or the UK or even in the US? That makes great sense to me. I think that that's happening in some cases. But again, there are some idiosyncrasies of the Canadian system that we have to take into account. But I think there's effort at Health Canada to try and streamline this as much as possible. At least that's what I understand. But I'm not an expert in this.
Thank you very much for coming today and sharing your valuable information, expertise, and wisdom with us. And I would like to say that we now are going to go in camera because we have some work to deal with. So thank you again very much. And I suspend this while the witnesses leave. Thank you.